Bismillahirrahmanirrahim. Quote of the day. Raise your words, not voice. It is rain that grows flowers, not thunder. Today, the topic of my presentation is hemoglobinopathies, and I am presenting it under supervision of my professor, Dr. Sarah Afzal. Learning outlines of our presentation will be introduction to hemoglobinopathies, introduction to sickle cell disease, its cause, types, symptoms and complications, inheritance and management, introduction to thalassemia, its variants, clinical features, management and prevention, and screening of hemoglobinopathies, and in the end, recent updates and MCQs. Learning outcomes. By the end of this presentation, participants would be able to describe the most common hemoglobinopathies, their variants, management, and prevention. Now, what is hemoglobinopathies? Hemoglobinopathy is a kind of genetic defect that results in abnormal structure of one of the globin chains of the hemoglobin molecule, and these are inherited single gene disorders. These could be of two types. Unusual genes that affect the quality and structure of hemoglobin, which are called as hemoglobin variants, and among these, the very most common and prevalent is sickle cell disease, which is due to the hemoglobin S. Others are hemoglobin O and hemoglobin A. And the other is unusual genes that affect the quantity of hemoglobin, and it includes thalassemias, which are further classified as alpha or beta thalassemia. Now, change in structure and quality of hemoglobin. Hemoglobinopathy is where the mutation results in a change to the structure and quality of hemoglobin. They are known as hemoglobin variants. And the most important of these is sickle cell, that is HBS. Other hemoglobin variants which have a genetic and possibly clinical significance are hemoglobin C, hemoglobin D, O, E. Hemoglobin E is technically a hemoglobin variant. However, it is also interacts with beta thalassemia to cause a significant clinical condition, so it can be classified as thalassemia's category. The other reason of hemoglobinopathy causation is reduction in quantity of hemoglobin. Now, thalassemia is the name for a group of related conditions where the amount of hemoglobin that the body produces is reduced, and this impacts on its oxygen carrying capacity. These usually affect either the alpha or beta globin chain. The most significant of these are beta thalassemia, delta thalassemia, and alpha thalassemia. Now we'll discuss sickle cell disease and thalassemia in detail. Sickle cell disease. In sickle cell disease, the beta chain is affected by a mutation that results into a formation of an abnormal hemoglobin, that is hemoglobin S, and it is formed by a point mutation in which glutamic acid is substituted with valine at position 6 in the beta hemoglobin chain gene. Now, global prevalence. It affects millions of people throughout the world and is particularly common among those whose ancestors came from sub-Saharan Africa and Spanish-speaking regions in the Western Hemisphere, South America, Caribbean, Central America, Saudi Arabia, India, Mediterranean countries such as Turkey, Greece, and Italy. An estimated 3.2 million people in the world have sickle cell disease, with about 80% cases occurring in Africa. And one of the distinguishing note about it is that it occurs more often among people from parts of the world where malaria is or was common, and it is believed that people who carry the sickle cell trait are less likely to have severe forms of malaria. In Pakistan, about 0.5 to 1% of Pakistani population carries hemoglobin S or hemoglobin E. Nevertheless, the exact prevalence is not established. Now, normal hemoglobin have the following types. It is hemoglobin A, consisting of 2 alpha and 2 beta chains. Then comes hemoglobin A2, which consists of 2 alpha and 2 delta chains, and hemoglobin F, which consists of 2 alpha and 2 gamma chains. Hemoglobin F actually normally predominates in the first year of life. After that, hemoglobin A predominates, that is 96%, with HbA2 making about 2 to 3%. Now moving into types of sickle cell disease. Simply the presence of HBS makes the disorder so-called a sickle cell disease, and the types are sickle cell anemia. It is homozygous form in which both hemoglobin are HBS. So it is the severest form. Then comes sickle cell trait, which is heterozygous with half of hemoglobin being normal and half being sickle. That is HBS and HbA. No symptoms unless under low oxygen tension. Then comes sickle cell beta thalassemia, which is also heterozygous form, but with the concentration normal hemoglobin being higher than sickle hemoglobin, and it is a mild form. Then comes hemoglobin SC disease. There is no normal hemoglobin. Its form is HbS and HbC, and its presentation is similar to that of sickle cell anemia, except that it is mild and less frequent, but it is the second most common type of sickle cell disease. And similar mutations forms HbC, except glutamic acid is substituted by lysine, whereas in HbS disease, it is substituted by valine. Now, genetics of sickle cell disease. The change in cell structure arises from a change in the structure of hemoglobin. A single change in amino acid causes hemoglobin to aggregate. Here we can see that this is normal hemoglobin, and in HbS hemoglobin, glutamine is substituted by valine. Now, inheritance of sickle cell disease. If one of the parent is carrying a trait and the other one is perfectly normal, then there is a chance that the 50% of the children would be having sickle cell trait, while 50% would be normal. And if both parents have sickle cell trait, then there is a chance that 1 in 4 would be anemic, that is sickle cell anemia, and 50% of the children would be having sickle cell trait, while 25% of the children will be perfectly normal, genotypically as well as phenotypically. And if one of the parent is sickle cell anemic and the other one is carrying sickle cell trait, then 50% of the children would having a sickle cell anemia, while 50% of the children would be just sickle cell trait positive. Then if one of the parent is having sickle cell anemia, that is sickle cell disease, and the other parent is perfectly normal, that is not affected, having hemoglobin AA, then there would be chance that all of the 4 children would be having sickle cell trait. Now, pathogenesis. When sickle cell hemoglobin gives up its oxygen to the tissues, hemoglobin as sticks together, forms long rods, form inside RBCs, and RBC become rigid, inflexible, and sickle-shaped, and unable to squeeze through small blood vessels, so blocking them, and less oxygen to the tissues of bodies delivered. RBCs containing HbS have a shorter lifespan, that is of 20 days. However, as we all know that normal RBCs have 120 days span life, and it is the chronic state of anemia. Here we can see that is the normal RBCs, spherical in shape, and this is the picture of sickle cell anemia in which the RBCs have formed sickle cell shape and clogging the blood vessels. Now, symptoms and complications. The symptoms include the very common is the sickle cell anemia, and then due to the formation of microinfarcts, it can lead to cerebral infarct, stroke, retinopathy, cardiomegaly, leading to congestive heart failure, cholelithiasis, renal infarcts, bone marrow hyperplasia, and infarcts of the extremities, pulmonary infarcts leading to pneumonia, splenomegaly, and splenic atrophy, which is also called autosplenectomy. Its acute complications include acute pain, acute chest syndrome, priapism, acute splenic sequestration. And chronic complications are chronic pain, cerebrovascular disease or stroke, pulmonary hypertension, leg ulcers, avascular necrosis of hip, shoulders, and renal failure. Now, chief cause for admission of patients in sickle cell crisis are vaso-occlusive crisis, which further consists of pain crisis, panic sequestration, acute chest syndrome, aplastic crisis, hemolytic crisis. We will discuss detail further. Now, the factors that can precipitate sickle cell crisis are infections, low oxygen tension, and concomitant medical conditions, dehydration, acidosis, extreme physical exercise, and physical or psychological stress, alcohol, pregnancy, and cold weather. Now, vaso-occlusive crisis, it arises due to obstruction of microvasculature by rigid sickle cells. A painful crisis is that it can affect any part, but it is chiefly experienced in the abdomen, bones, joints, soft tissues, and starts suddenly very severe, and it may last for several hours. And commonly long bones are affected, but in the first 18 months can involve metatarsal and metacarpal cholecystectilitis, which is very painful swelling of hands and feet. Then comes splenic sequestration. When vaso-occlusion occurs in the spleen, the microvessels are blocked and blood accumulates in the spleen, and there is rapid enlargement of spleen, which is very life-threatening medical condition, and it is very common in first 5 years of life, and it can lead to the splenic infarction or splenism at the end of childhood, and it can worsen the baseline anemia, increases risk of infection by encapsulated organism, that is H. influenza, S. pneumonia, S. typhi, and meningitis. Then comes acute chest syndrome, which is commonly characterized by chest pain, fever, cough, tachypnea, pulmonary infiltrates, hypoxemia. It is also a medical emergency, and it is commonly precipitated by chest infections in children. Then comes aplastic crisis, which is worsening of baseline anemia due to infection of parvovirus B19. And the third crisis is hemolytic crisis, which is accelerated breakdown of RBC that occurs with coexistence of G6PD deficiency. Then how we diagnose anemia? First, first from family history and clinical manifestations, then to newborn screening and lab tests. In lab tests, we have increased retic count, decreased hemoglobin and hematocrit, and total iron binding capacity. And the very important tool to diagnose is hemoglobin electrophoresis, which reveals predominantly hemoglobin S. And in this it is normocytic, normochromic sickle cell cells we can see in peripheral blood smear. And the CBC shows normal MCV, MCH, MCHC, and normal serum iron and serum ferritin. Treatment is usually aimed at avoiding crisis, relieving symptoms, and preventing complications. Babies and children aged 2 and younger with sickle cell anemia should make frequent visits to a doctor, and children older than 2 and adults with sickle cell anemia should see a doctor at least once a year, according to CDC. And treatments might include medications to reduce pain and prevent complications, and blood transfusions as well as bone marrow transplant. So medications include antibiotics, like children with sickle cell anemia, they should be taking penicillin when they're about 2 months old and continue to take it until 5 years of their age. And doing so, it prevents infections such as pneumonia, which can be life-threatening to an infant or child with sickle cell anemia. And as an adult, if a patient had splenectomy or had pneumonia, he should also be taking penicillin throughout his life. Then comes pain relieving medications, that is to relieve pain during sickle cell crisis. Then comes hydroxyurea, which are taken daily to reduce the frequency of painful crisis. And others management lines are assessing stroke risk. And very important thing to remember is that vaccinations should be done to prevent infection, like childhood vaccination, very important for preventing disease such as pneumococcal vaccine and annual flu shot. They are important for adults and with sickle cell anemia. Then comes blood transfusion, nitric oxide, because people with sickle cell anemia have low levels of nitric oxide in their blood, so they should be given. And bone marrow transplant and stem cell transplant offers very potential cure for sickle cell anemia in the last gene therapy. Now, infections in sickle cell disease. It is the most common cause of death in children, but a major problem at all ages. Due to splenic infection from sickle damage, it occurs from a few months of age, and due to the certain bacteria, for example, pneumococcal sepsis, and infection can be rapidly overwhelming. And infections can be prevented by giving education, and giving vaccination, pneumococcal, Haemophilus influenza, and meningococcal vaccines, and travel prophylaxis for malaria endemic areas, and in the last, aggressive treatment of infections. Now we move on to our second, the most common hemoglobinopathy, that is thalassemia. Problem statement. Globally, thalassemia is the most prevalent yet preventable genetic blood disorder affecting populations in the Mediterranean area, Middle East, Central Asia, Indian subcontinent, and Southeast Asia. It affects approximately 4.4 out of every 10,000 live births throughout the world. Advances in thalassemia care management combined with the commitment of government in many parts of the world have transformed thalassemia from a childhood fatal disease to a chronic disorder requiring multidisciplinary care and compatible with normal life expectancy. But unfortunately, this is not the case in Pakistan. Now, introduction. Genetic as we know that thalassemia is a genetic blood disorder resulting in mutation or deletion of the genes that control globin production. In this, there is quantitative defect, that is decreased production of globin chains, either of 2 alpha or 2 beta gene globins. Mutation in a given globin gene can cause a decrease in production of that globin, resulting in deficiency. So the other globin chain aggregates and becomes oxidized, damaging the cell membrane, leading either to hemolysis, ineffective erythropoiesis, or both. Now, this is thalassemia classification. It is further classified into alpha thalassemia and beta thalassemia. And beta thalassemia is further classified into thalassemia major, thalassemia intermediate, thalassemia minor. We are going to discuss in detail further. Alpha thalassemia, it is the most common, and how it is produced is that when a gene or a genes related to alpha globin proteins are missing or changed, that is mutated. Alpha globin chains are absent or reduced in this type of thalassemia, and alpha trait, heterozygous trait, is asymptomatic in about 30% of African Americans, and alpha thalassemia occurs most often in people from Southeast Asia, Middle East, China, and those of African descent. Now, these are the alpha thalassemia variants. First is alpha thalassemia or silent carrier, in which one of the 4 genes is deleted, and it is asymptomatic phenotypically. Then comes alpha thalassemia trait, in which 2 of the 4 genes are deleted on chromosome 16. So sign and symptoms, that is from asymptomatic to small, pale, red blood cell and mild anemia. Then comes hemoglobin H disease, which results due to the deletion of 3 out of 4 genes. And it is characterized by moderate to severe hemolytic anemia, modest degree of ineffective erythropoiesis, splenomegaly, variable bone changes. Then comes a very serious condition, that is alpha thalassemia major or HP BARTS, in which arises due to deletion of 4 of 4 genes, and it causes non-immune hydroxyspitalis, which is very usually fatal. Then comes beta thalassemia, when it occurs when similar gene defects affect the production of beta globin proteins. So beta globin chains are absent or reduced in this type of thalassemia. It mostly occur often in people of Mediterranean origin. Chinese, Asian, and Africans are less affected. Beta thalassemia in Pakistan. Beta thalassemia is one of the most inherited disorders in the country, with the prevalence rate of 6% in the Pakistani population. There are more than 50,000 thalassemia patients registered with association and treatment centers all over the country. Sorry. Then variants of beta thalassemia. These are normal, which has no significant signs and symptoms phenotypically. Then comes beta thalassemia minor, in which it could be asymptomatic to mild microcytic hypochromic anemia. Then comes beta thalassemia intermediate, in which there is a variable severity from mild to moderate anemia to possible extramedullary hematopoiesis, iron overload. Then comes beta thalassemia major, which is also called Coles anemia, and it is characterized by severe anemia, transfusion dependence, extramedullary hematopoiesis, and iron overload. Thalassemia major. The child born with thalassemia major has two genes for beta thalassemia and no normal beta chain gene. The child is homozygous for beta thalassemia. It causes striking deficiency in beta chain production and in the production of hemoglobin A. Treatment for these patients includes chronic blood transfusion therapy, iron chelation, splenectomy, allergenic hematopoietic transplantation. Then thalassemia intermediate is milder than thalassemia major. The signs and symptoms of thalassemia intermediate appear in early childhood or later in life, and affected individuals have mild to moderate anemia and may have also growth and bone abnormalities. Then comes thalassemia minor, which is caused by heterogeneous mutations that affect beta globin synthesis, and it usually present as mild asymptomatic hemolytic anemia unless patient is under stress such as pregnancy, infection, folic acid deficiency, and it has one normal beta gene and one mutated beta gene, and it generally requires no treatment. And in this we have to make patients sure that they are not diagnosed with iron deficiency anemia. Now, inheritance. It has the same pattern of inheritance as those of sickle cell anemia. That is, if both parents carry normal or healthy beta globin chains, then the children will be healthy. And if one of the parent carries an affected beta globin chain, beta globin gene, then he is a beta thalassemia carrier. So 50% of the children would be healthy and 50 would be carrying beta thalassemia trait. And if both parents carry the beta thalassemia trait, then 25% would be thalassemic, 50% would be carrying beta thalassemia trait, and 25% of the children would be healthy. Now, diagnostic evolution. It is done through history collection. Then comes physical examination, which usually reveals splenomegaly. Then comes CBC, which reveals microcytic hypochromic anemia. And if we recall sickle cell disease, in that we have normocytic normochromic anemia. Then comes peripheral blood smear, which reveals that RBCs are small and abnormal in shape when looked under microscope. Then a test called HB electrophoresis. It shows the presence of an abnormal form of HB. And mutational analysis, which detects alpha thalassemia. Then comes amniocentesis, which is diagnostic tool for prenatal diagnosis. Then comes molecular diagnostic test that determine whether a mutation is present after 8 weeks of gestation. Then comes management, medical management. Thalassemia minor usually does not require treatment, but for thalassemia major, the treatment goals are to provide adequate normal hemoglobin for erythropoiesis and to alleviate the effects of iron overload, or its treatment goals involve regular blood transfusion and folate supplements. During blood transfusion, the client should not take supplements because doing so can cause a huge amount of iron to build, which can be harmful. Chronic transfusions are administered to correct anemia with the targeted hemoglobin level at 9 to 10 milligram per deciliter. Iron chelation, that is chelation therapy with defuroxamine, is necessary to prevent iron overload by removing excessive iron from body. And the very important, that is genetic counseling and testing for families should be encouraged. Surgical management includes bone marrow transplantation, especially in children, and splenectomy should be done to decrease transfusion requirements. So the available therapies to cure thalassemia: blood transfusion, drugs, hydroxyurea, and stem cell therapy, gene therapy, and gene editing. Now, prevention efforts. Premarital screening should be done to make sure that the couple are not both carriers. and provision of counseling and health education for the thalassemics, their families, and the public, provision of prenatal testing for thalassemia, reduction of marriages between relatives. Now, prenatal diagnosis and prevention. The birth of beta thalassemia major child can be prevented. That is, couples who are aware that they are carriers of beta thalassemia may undergo prenatal diagnosis, that is by amniocentesis, cardiocentesis, chorionic villus sampling to prevent the birth of an affected children. And the prenatal diagnosis method used in Pakistan is chorionic villus sampling. Then comes hemoglobinopathy screening, which includes newborn screening. It identifies which individuals have sickle cell disease or thalassemia. These conditions can influence an individual's long-term health or survival. Correctly screening for sickle cell disease and thalassemia is important to help individuals and their families get connected to healthcare services, treatment, and support groups to help manage the condition and improve long-term health. Now, what is needed by newborn screening programs to perform effective hemoglobinopathy screening? If Hemoglobinopathy screening programs, as we know, that differ by location and available resources. So it is important that all newborn screening programs should have access to information about the condition for which they screen, use the correct technologies to perform screenings, and appropriately report screening results to healthcare providers and families, and understand the impact that these conditions have on individuals identified through newborn screening. Now, moving on to recent updates. First is CDC Sickle Cell Data Collection Program. Actually, this is the program that it targeted to gather health information from multiple resources to determine how many people live with that disease in a particular state. It is currently actively being carried out in US. And the SCDC program helps to better understand it, where people with SCD live, and and better understand that older patients with SCD, that is people with sickle cell disease, are living longer, making it more important to use SCD's information to study common health problems and the use of healthcare services. SCD's information can identify how often people with sickle cell disease use healthcare services, for example, the emergency department, and what factors may lead to high use of these services. Now, the SCDC program's future steps that additional support become available. The SCDC program can include more states. An expanded sickle cell disease information system can determine how many people live with sickle cell disease in the US, how sickle cell disease affects their health, and how researchers can improve medical treatments to extend and improve the lives of people with sickle cell disease. Now, this is an article which was published last year about the thalassemia in Pakistan. The current status of thalassemia is highlighted in this article, and according to it, Pakistan is among the highest thalassemia burden countries in the world, with 100,000 transfusion dependent thalassemia patients. And in the absence of a coherent national policy and strategic plan, the number of thalassemics in the country is believed to be increasing, but the exact burden of the disease is unknown. As a result, despite being a preventable blood disorder, thalassemia in Pakistan continues to increase in number and causing misery to patients and their family. So it creates a heavy burden on the already resource constrained and stretched national healthcare system. As no baseline survey have been conducted in Pakistan, so no credible statistics about any aspect of thalassemia in the country. Basic epidemiological and clinical data about the national thalassemia population do not exist. Information is not available about treatment facilities and the access to to patients. And without this basic information, it is difficult to convince the policymakers about allocating resources to control and prevent the thalassemia. Now, this is Thalassemia Federation of Pakistan. It is an umbrella organization of all the societies working for thalassemia in the country, and the purpose is to support the various associations nationwide which work for the cause of treatment and prevention of thalassemia. And its aim is to provide the associations with any assistance they need to provide all the required support, including treatment and prevention services to thalassemics and their families. Then the COVID-19 pandemic and the hemoglobin disorders. This was a contribution of Thalassemia International Federation to its global patients community. According to it, the sickle cell disease, the SARS-CoV-2 infection may trigger such as serious complications and require special alertness on behalf of physician treating infected patients. In addition, any hypoxia, dehydration, acidosis due to respiratory infection may trigger a vaso-occlusive crisis. While in thalassemia, patients do not have the same risk of lung infections as patients with sickle cell disease. Now, this is that during the last 3 years, Pakistan Baitul Mal has provided financial assistance to more than 3,000 thalassemia patients, keeping in view the importance of Thalassemia Center and to cater the patients Pakistan's, especially Azad Jammu Kashmir, northern areas, Gilgit Baltistan. A state-of-the-art Thalassemia Center have been established for free of cost treatment by Pakistan Baitul Mal, and during year Jan to December 2020, 9,330 thalassemia patients served, that is blood transfusion, iron chelation, ferritin test, LFT, RFT test in Pakistan Thalassemia Center. Now moving on to multiple choice questions. MCQ number 1. Hydrops fetalis is a clinical condition caused by deletion of the alpha genes of hemoglobin. Among a total of 4 alpha genes, the hydrops fetalis is caused by deletion of 1 alpha gene, 2 alpha gene, 3 alpha genes, 4 alpha genes. Any guess?
D.
Yes, D. Hydrops fetalis, which is usually a fatal condition, it is due to the deletion of 4 alpha genes. D is the right option. MCQ number 2. Sickle cell disease is an inherited blood disorder of hemoglobin synthesis. Identify the correct answer from the following. It is caused by mutation in the sixth position of alpha chain, that is glutamic acid is replaced by isoleucine. Caused by mutation in the sixth position of beta chain, glutamic acid is replaced by isoleucine. Or caused by mutation in the sixth position of alpha chain in which glutamic acid is replaced by valine. Or caused by mutation in the sixth position of beta chain in which glutamic acid is replaced by valine.
D.
Yes, D is the right option. MCQ number 3. Which of the following conditions worsen symptoms associated with sickle cell disease? Decreased pH associated with exercise, increased fetal hemoglobin, increased hemoglobin C, increased oxygenation.
A.
Yes, A is the right option. MCQ number 4. Which of the following is most commonly characterized by iron overload? Alpha thalassemia, beta thalassemia major, sickle cell disease, hemoglobin S.
B.
Yes, right answer is B, that is thalassemia major, because in this multiple blood transfusion are given, so patients usually go in iron overload. MCQ number 5. Mr. and Mrs. Ali both are positive for sickle cell trait. They went to doctor for genetic counseling before start of a family. They were counseled about the chances of disease in their offspring. Which of the following could not be the possibility? 1 in 4 would be perfectly normal. 1 in 2 could acquire the trait. 1 in 4 would have a disease. All of the 4 would have a disease.
D.
Yes, D is the right answer because both are sickle cell trait positive. So it is not the possibility that all of the 4 would have a sickle cell disease. MCQ number 6. A 6-year-old boy known case of sickle cell disease developed abrupt onset of chest pain associated with distal cough followed by 4-day history of chest infection. He was taken to medical emergency to get prompt relief of his symptoms. What is he most likely suffering from? Acute chest syndrome, acute coronary syndrome, painful crisis, hemolytic crisis.
D.
No, A, acute chest syndrome. It is a very common in children, which is usually followed by chest infection, and the symptoms correspond to that of acute chest syndrome. MCQ number 7. A child was born to couple who were thalassemia trait positive. The newborn screening revealed him thalassemia trait. Later on, he developed mild symptoms of anemia. What would be the best treatment option for him? Blood transfusion, iron chelation, bone marrow transplantation, no treatment required.
C.
No, D is the right answer because since his parents are thalassemia trait positive, so he is thalassemia trait positive. That is, he is having thalassemia minor, and usually no treatment is required. MCQ number 8. Splenic scitration is one of the complications of sickle cell disease that occurs when vaso-occlusion occurs in spleen, leading to blockage of microvessels and accumulation of blood in spleen. Which of the following is not true about it? It is a life-threatening medical condition. It is common in adulthood. It worsens baseline anemia. It causes increased risk of infection caused by encapsulated bacteria.
D.
B.
Which is not true. The right option is B. That is, it is very much common in childhood, especially in first 5 years of life. So B is the wrong option. MCQ number 9. Pakistan is among the highest thalassemia burden countries in the world with 100,000 transfusion dependent thalassemia patients. The birth of thalassemia major can be prevented if known carrier parents go for genetic counseling, prenatal diagnosis, gene therapy, stem cell therapy.
Alpha. Genetic
Yes, genetic counseling could also be the right option. The best option here is prenatal diagnosis. MCQ number 10. Infection is the most common cause of death in sickle cell disease, especially in children due to splenic dysfunction. This can be prevented by giving all of the following except penicillin, cephalosporin, pneumococcal influenza vaccine, travel prophylaxis for malaria and endemic areas.
D.
The right option is B, cephalosporins. It is not given for the prevention of infection. This is the key of my MCQs. These are the references. Thank you.
Okay, thank you very much. Very nice presentation, Meha.